Hello, everyone. Welcome to our live session for the NCLEX-style review. And if this is your first time joining us, we are currently on day 23rd of our 90-day NCLEX review series, which is completely free. And throughout the series, we are covering a broad range of nursing topics and tackling 2,000 NCLEX questions with a detailed rationales. I need you to spread the word to your friends preparing for the NCLEX. So our classes are free of charge. And don't forget to like and subscribe and enable the notifications to stay updated with our latest content. Now, for more details, check out the description box below. And we value your feedback. So please share your thoughts or questions in the comments, and we will gladly provide further explanations on any topics. And you know, guys, that we're still offering the course, the NCLEX review course, at our website. So check out at www.stancoast-nclexcoaching.com for personalized guidance. And the program makes studying fun with engaging lectures and over 3,000 NCLEX questions. So check out our 10-hour animated video course and enjoy 100 hours of prep time. So you can access this with our video library and practice mock exams to build your confidence. And you can get 6 months of full access, including 200 NGN questions to be well prepared for the exam. And you can study at your own pace with your flexible platform. And of course, we are going to support you every step of the way. Now, we are going to focus today on the nursing management for a patient with an asthma. So let's get started. Now, here we go. We are looking into the different photos about the terminal bronchioles. Okay, so these are the different appearances, especially when you're seeing a normal airway or a person that may have an asthmatic airway, and also an airway that may look like whenever there is an acute attack. Now, let's define first, what is an asthma? Well, basically, this is a disorder which is identified by the three following features. And one of those is the airway inflammation, wherein there is going to be narrowing of the passageway. And there's also going to be increased airway responsiveness. So what does that mean? Well, the bronchi, the bronchioles are going to be sensitive around this time, and they will become reactive to the various stimuli or triggers that in a non-asthmatic individual. So this heightened sensitivity will lead to a much more exaggerated response and will result into bronchoconstriction. We call it the narrowing of the airways, and it will also lead to some more inflammation and increased mucus production. So all in all, this is really gonna make the breathing way too difficult. Now, another feature here is the reversible blockage of airflow, which simply means that it can be treated with the use of the bronchodilators or with the use of the other medications. Let's say the anticholinergics, could be the beta-2 adrenergics, and so many more. Now, guys, take note that the asthma can be classified into two different types. One is the extrinsic, or we call it as the atopic type of asthma. So what does it mean? Well, the onset of this type actually can begin in childhood, and this is more associated with other allergic reactions or conditions, maybe due to eczema, or could be hay fever. And most of the triggers here are caused by exposure to pollens, or it could be household dusts, molds, it could be cockroaches, cats, and dogs. So those are the most identifiable triggers that can really cause this person to have an asthma attack. Now, there's also viral infections, could be the presence of cigarette smoke, or maybe with exposure to any medications. Maybe they probably used, or maybe there's a chance, or maybe they probably use some aspirin or beta blockers, which could really precipitate the asthmatic attack. Now, for the intrinsic non-atopic type, this is going to occur at actually at later time. So mostly around adulthood or later, or maybe around teenage years. And this simply means that the patient might have the trigger because of some respiratory infections, or it could be presence of stress, or maybe exercise, and the presence of cold air as well, or let's say extremes in the temperature can also trigger the asthma attack. All right. Now, there's also going to be presence of smoke or exposure to that, especially strong odors or perfumes can also lead to this asthma attack for this person with a non-atopic type. Now, to recap this section, we really want to identify the different triggers, especially for the intrinsic. And because we are really going to make sure that we are able to identify those triggers, those allergens, especially. Because sometimes we can get confused with how the person get that attack, or let's say we really don't know for sure if we are not assessing well with their medical history. So we really need to get into their prior history of the attack and make sure that we are identifying those common triggers that they might have in the past as well. Now, we are also going to have to talk about the different classifications of the asthma according to the severity. Okay, so we have split this into 4 different classes. We have the intermittent, there's also the severe, there's the moderate, and we'll go through each and we will simplify this one. So the asthma itself is going to be varied according to the symptoms that will occur and how much they're going to affect the patient's life. And so we're going to have to describe those symptoms according to the components, let's say their risks, how often they're going to be awakened at night, or let's say with the use of the short-acting beta-adrenergic agents, or let's say with the interference of asthma in their daily lives. And we're also going to talk about the forced expiratory volume of this patient and the different stages or severity. And we're also going to talk about the FEV1 and also the FVC, and also the risk of an asthma exacerbation requiring oral corticosteroid first. Okay, so we're going to have to start with the intermittent first. So what does this mean? Well, the person will have at least less than or equal to occurrences of the symptoms at least twice in a week. Okay, so the person here with an intermittent case of asthma, they're going to have that few times a week. All right. Now, as far as the nighttime awakening, this is going to indicate how often the asthma is going to wake them up. And so with this type, the person is not waking up at night much. And if it happens, it will occur less than twice a month, okay, or equal to 2 occurrences in a month. Now, if we're going to refer it to with the use of the short-acting beta-adrenergic, we call it the rescue inhaler. They're probably reaching for the rescue inhaler less than twice a week, okay? Usually when they really need that medication. Now, as far as like interference with the normal activity, well, there's really none. It doesn't really interfere with their lifestyle. However, though, with the use of the SABA or the short-acting bronchodilator, they're not usually going to be affected, especially if they're exercising, okay? So that's the big deal right there. Now, for the FEV, which is basically the amount of air that a person can exhale forcefully within 1 second, this is what we call as the FEV1. And this is really an important diagnostic test that should be determined for this patient with an asthma. And so at this point, when they're going to be tested for the FEV1, they're going to have at least more than 80%. Okay, so this simply means that their lungs are working well, and this is more than 80% of what's expected. All right, so take note of that FEV1. However, if we're going to look into the FEV1 and the FVC ratio, they're going to have a normal ratio showing that their lungs are in good shape. However, though, with the risk on the asthma exacerbation, let's say possibility of using an oral corticosteroids, well, they might have some kind of flare-ups, let's say maybe 0 to once in every year. Okay, so not too bad for the person with an intermittent type of asthma. Now let's move forward with the mild persistent type of asthma. So here, this means that the symptoms are starting to show up more often, but they're still manageable. Okay, so they now have more symptoms. And so in a week's time, they're going to have at least 2 days of the appearance of the symptoms. They're not going to experience it at daily frequency, but just twice a week. Now, as far as the nighttime awakening, the person is not really going to be awakened nightly. However, they might wake up at least 3 to 4 times a month. Okay, and they're awakened because of the shortness of breathing. Now, as far as like the SABA use, or the short-acting bronchodilator, they're probably going to be using this more than twice a week, but not every day. And also with the daily activities, there might be some kind of like minor limitation because it can make them really short of breath. It can trigger their symptoms. And so they're gonna probably not wanting to do any more exercise because of the shortness of breathing. Now, also, the person will have the limitation in what they can do daily, but they can still manage most of the activities. Now, talking about the FEV1, again, the forced expiratory volume 1, their lung function is still pretty good, around 80% or more than what is expected. So take a look into the comparison, pretty much the same with the intermittent. Now, talking about the FEV1 and the FVC ratio, there's going to be some normality in that ratio, showing that their lungs are handling the airflow well. However, though, if you're going to talk about the risk of an asthma exacerbation, so they might experience some flare-ups, at least 2 or more in a year. And so this person might need some oral steroids, let's say prednisone, in order to control their asthma. Okay, so please take note, they are going to have at least flare-ups of 2 occurrences in 1 year, thus prompting the need for an oral corticosteroid. Okay, and this is under the mild persistent. Now let's talk about the third type here, and we are on the moderate persistent. So this means that the person may have the symptoms every day, and this can really affect what they're doing. Okay, so again, it's gonna be daily, so that's kind of like troubling, right? You probably would not be able to do a whole lot with so many things, especially engaging in physical activities because of the shortness of breathing, right? And it's gonna be constant appearance of the manifestations. And during at night, when they're sleeping, of course, they will be awakened at least once a week, but not nightly. And they're going to be expected to use their rescue inhaler in a daily manner, okay? Every day, because of the daily appearance of the symptoms, okay? So that is expected. They're going to be using the rescue inhaler in a daily basis. And of course, with the exercise, they're gonna end up with some bronchospasm. It will trigger their asthma symptoms. So it's really gonna make their physical activity very hard. if they're going to do that. Now, as far as the interference with the physical activity, it's really going to get in the way of their lives, and they will find themselves very limited in what they can do daily as well. Now, talking about the FEV1, which is the forced expiratory volume in 1 second, their lung function is significantly reduced with a range of 60 to 80% of what is expected. Okay, so if you don't have any asthma, maybe you don't have it. So our FEV is expected greater than 80%. All right, you will not experience any shortness of breath when you are engaging in a regular daily activity, maybe some walking. It will not cause you some extra effort. Okay. Now, talking about the FEV1, FVC, there's going to be a reduction of about 5%. Okay. Now, this is really going to impact on the lung function as well. And this person, talking about the exacerbation, they probably would have more frequent flare-ups, and they would really require the oral steroids, or let's say the prednisones, more than twice a year. So that is quite disturbing as well. Now, we're going to talk about the last type right here, which is basically the severe persistent type of asthma. And the symptoms here will become more intense and persistent, and all the time gonna impact their life as well. Now, we're gonna talk about the symptoms here with, of course, they're gonna deal with this. Seems kind of like throughout the day. It's relentless. And at nighttime, when they're trying to get some sleep, it's gonna wake them up at least 7 times per week. So you're gonna expect this person really fatigued, not getting enough sleep. Maybe they're going to end up with some form of insomnia. And this is a chronic thing. And so this is really going to impact their overall health as well. Now, for the use of the SABA, this is going to cause them to use that rescue inhaler several times per day. So that simply means that they're not managing their asthma pretty well. This is really going to call for immediate attention, medical supervision, because with that, the person has occasional or actually frequency in the bronchospasm. And also with the exercise, this can really trigger severe symptoms. Probably it can cause status asthmaticus. It's really going to make daily activity very challenging. Now, the person will have a lot more of limitation in their daily activities, even doing simple stuff, let's say cooking or maybe showering, can be somewhat difficult for them to do. Just very simple chores at home can be challenging for them. Now, as far as the FEV1, there's going to be significant reduction, less than 60% or maybe lesser. And the ratio for the FEV-FVC is going to be notably decreased. And really, it's telling us that the patient's lung function is significantly affected. And now, if we're talking about the exacerbation and the need for them to use an oral corticosteroid, well, they're gonna require that medication, and also there's that frequent and intense events. Okay, so yeah, the person probably would miss a whole lot of many physical activities. Probably they're not going to be able to participate with any kind of socialization or any kind of simple task. Let's say doing groceries, probably would not let they would not be able to do those kind of activities anymore. Now, guys, I hope that you're able to capture those 3 different levels of severity in asthma, because we're gonna really probably gonna be asked about the FEV1 and the FEV1 ratio with the FVC. So these are the things that you need to really recall, especially if you're going to be asked this type of question in the exam. All right, FEV1 is something that you need to be familiarized. Now let's talk about the assessment findings. And in this slide, I did not really include everything. I am just putting in a few of the manifestations that will be often seen in a person with a mild type of asthma. And so with this, they're gonna have some shortness of breathing, and of course, they're going to have some wheezing as well. And this is going to be heard more in the expiratory phase. And then if it gets a little bit more difficult, then you probably hear the inspiratory wheezing as well. Okay. And this would be your hallmark in assessing the patient with an asthma. Now, there will be some sensation of chest tightness, and they're also going to be coughing. And of course, the symptoms would really vary. They probably would not carry all of the symptoms that I'm listing here, but typically within 30 minutes of exposure to the common triggers, they probably would manifest more and more of those clinical findings. Okay. Now, talking about the diagnostic test, well, make sure that you are going to stick to this one. The first diagnostic test that is really essential for diagnosing the asthma are this pulmonary function test, or we call this the PFTs, because this is going to reveal the obstructive pattern and also the reduction of the expiratory flow rates. And this will also tell us the decrease in the forced expiratory volume and also the FEV1 FVC ratio, which I've shown you earlier according to the severity. Now, another diagnostic test is the spirometry, which is going to be done before and after a bronchodilator in order to confirm the diagnosis, of course. Now, this is also going to include inhalation of a bronchodilator, especially a beta-2 adrenergic agonist. And also, no, I'm talking about if there is an inhalation of a bronchodilator, I should say, this will increase their FEV or FVC by at least 12%. And so you got to be careful, make sure that you are determining first if the patient just had any bronchodilator before the testing, because this can really give them a false negative result. Okay, so you have to talk to the medical provider if you're supposed to withhold or just administer the scheduled bronchodilator before the testing. Now, talking about the peak flow, which is another testing here. This is going to measure the airflow obstruction, and this is something that every asthmatic patient should know about. They should have that device that they can use at home in order for them to monitor their lung function. And so in the case of, let's say, mild persistent asthma, they need to have periodic checks, and this is going to be sufficient. And also this will require the person probably an increase in the dose of the steroid if the peak flow drops, okay? So again, in the mild persistent type of asthma, there's gonna be periodic checking and a possibility that the medical provider will have to include the steroid if their peak flow value will go down. Now, in case there is now a moderate persistent type of asthma, well, they're going to definitely need the testing in a daily basis. And this will also probably require the medical provider to include the dose of inhaled steroid, okay, when they're going to notice that there is a peak flow drop as well. Now, talking about the severe persistent type, okay, so here the patient will really need to do daily checks as needed, okay, and possibly the person here or the patient will require daily prednisone as well, or maybe much more frequent dose of prednisone if the peak flow drops, okay. Remember about the severe persistent findings that we talked about. They're going to have more of the symptoms at least 7 days a week. They're going to have to use that rescue inhaler at least 7 times a week as well. Um, a lot more times at nighttime, they're going to be awakened and they're going to have the exacerbation many times in a year. So definitely this person would need some modification in their lifestyle, and also the medication as well will need to be evaluated. Okay. Now there's also the test we call as the bronchoprovocation testing. Okay. So this is actually a test that will be useful when the asthma is suspected, but maybe the pulmonary function tests are quite inconclusive. And so this is going to assess the airways narrowing in response to a stimuli. So this is what we call as hyper responsiveness. So again, the bronchoprovocation test will assess how reactive the airways are and how fast it can narrow the airways in case it is exposed to some triggers, maybe an allergen. And around this testing, they're gonna be tested with their lung function before and after inhaling the dose of a medication we call as methacholine. Okay, so this is a drug that will be inhaled by the patient before or within the test itself. Okay, so again, their lung function will be measured before they're going to inhale the methacholine. Okay, so this is a medication actually that is considered as a muscarinic agonist, and of course this will really measure or will help in the determination if a person will have that easy responsiveness, hyper responsiveness to any kind of trigger. Now, lastly, we have or second to the last, the chest X-ray. So in a mild or let's say severe or moderate case, the chest X-ray will show some hyperinflation, and also it is going to rule out any other conditions. Maybe the patient probably have some kind of pneumonia, or could be pneumothorax, or it could be a foreign body, or it could be the pneumomediastinum. So the chest X-ray will really help out in determining if this is just merely asthma, or it could be other some problems, maybe the pneumonia that I mentioned, or the pneumothorax because of the presence of the air. Now, the arterial blood gases would also be helpful in the diagnosis of asthma. And of course, when you are looking into the results, there will be a drop in the oxygen level. Well, what's going on? Well, there is no proper passing of the gases or exchange of gas because of the narrowing of the airways. And during the early phase of the attack, what you're going to expect here is that the person's CO2 level, the partial pressure of the carbon dioxide, will be elevated. And I'm talking about the early phase. Their CO2 level will tend to be higher, which simply means that the person is hyperventilating. So there is what we call as hypocarbia, a reduction in the carbon dioxide early in the attack because of the hyperventilation. But during the later stage, the PaCO2, I'm sorry, I made the wrong sign right here. Let me redo that. So during the early phase, the PaCO2 level will drop. It's because of the alkalosis, because of the rapid breathing. So they're losing a whole lot of the CO2. However, in the late stage, their CO2 level will start to go up. Okay. And this is now because of the accumulation of the CO2. And this is going to be seen in the ABGs, which is going to be greater than 45 of CO2. Okay. As we know that the normal range is around 35 to 45 mmHg. Okay. Now, Remember, guys, that when we are taking care of a patient with asthma, they're going to end up with much more rapid respirations. And so think about the initial reduction of the carbon dioxide, and then it will eventually go up. Once they're going to be fatigued, their breathing is going to slow down a bit more. And so the carbon dioxide level will start to creep up. And this is going to give us a signal that the patient is leading towards respiratory failure. And so they're going to really require us to treat the hypoxemia, and also probably if they're not responsive to the oxygen therapy, bronchodilators, then they're going to end up in a mechanical ventilator, okay, with, of course, with the insertion of the endotracheal tube. Now, talking about the treatment of asthma, I want you to use this acronym, okay? Mean climb, okay? Again, this is the acronym that probably would help you in retaining those medications that are often used in the treatment of asthma. So that's mean climb. So that means that ME stands for the methylxanthines, okay? And then we have the AN, okay, let me write that down. ME stands for methylxanthines. Let me just write here ahead of time, methylxanthines. And this is represented by the theophylline. And then AN, that is for the anticholinergics. The inhaled anticholinergics, such as the ipratropium. Anticholinergics. And then we have the C, which signifies the corticosteroids. So it could be in the form of an oral or it could be IV. Corticosteroids. And then we also have the I. So what is the I? Well, that will represent the immunomodulators. Immunomodulators. And then we also have the M. What is that M? So that actually is going to represent the mast cell stabilizers. We have that represented by the cromolyn sodium, okay? Mast cell stabilizer. Don't worry, guys, I'll be explaining each classification in a moment. And then lastly, we have the B. That stands for the beta-2 adrenergic agonists, represented by the albuterol, which is a short-acting or rapid-acting beta-2 adrenergic agonist. Let me just shorten that as AG. Okay, so don't forget the mean climb, standing for methylxanthine, anticholinergic, corticosteroids, immunomodulators. We have the mast cell stabilizers and the beta-2 adrenergics. Now, talking about the first classification here, we have the methylxanthines, okay? This is actually an old medication used for the asthma. This is represented by the theophylline, okay? So the theophylline can be ordered in different forms. It could be given or ordered in the oral route, or it could be ordered as IV, okay? Now, the onset of the IV theophylline, it can work within about 15 minutes after the injection, and this can last for about 4 to 8 hours. So that's how the theophylline can work. Now, for the PO, this can work a little bit delayed, okay? The onset will work within 1 to 2 hours, and it can last for 12 to 24 hours. So guys, I want you to really understand that if the patient is given an oral medication, well, you're going to expect that the onset will be slower, right? However, though, the duration of action will be longer compared to an IV. The IV will have much shorter duration of action because it can get easily excreted by the body, especially the kidneys, or it could be the GI tract. So remember about those onset and the duration. Now, what is the effect really about the methylxanthines? Well, they are considered as bronchodilator as well. They are supposed to allow relaxation of the bronchial muscles. Now, you got to be careful in the administration of the methylxanthine because this is going to cause some side effects that are very serious. And one of those is the dysrhythmias. Okay. And the medication is not popular now compared to in the past. It's because the medication has that narrow therapeutic index. So it can cause some toxic effects if we are not really paying attention to the drug level. And in some cases, it can lead to seizure activity. Okay. So that is why we really need to be careful in administering this medication. Now, talking about the use of the methylxanthine, especially the theophylline, we need to keep an eye on the medication drug level, and the normal drug level range is somewhere between 5 to 15 micrograms per ml. So that is the safe or the therapeutic range. So if in case a person will have adverse reaction, this will call for immediate stopping of the medication or discontinuation. And if in case the medication has been given, then we need to do the activated charcoal. We're going to have to administer that via the NG tube, and also with the use of the lidocaine to counteract the dysrhythmias, and also to administer diazepam to control the seizures. So these are the known treatments to counteract the adverse effect. One is diazepam, the other one is the use of the lidocaine, IV. Lidocaine and diazepam. And if the medication has been given orally, then of course we're going to have to administer that charcoal through the nasogastric tube. Activated charcoal. Like I've said, guys, the use of the theophylline is not as popular nowadays because of these adverse effects. But still, in some cases, some of the medical physicians or the medical providers will still order this medication. So you gotta have to keep an eye out. Now, talking about the next classification of medication, this is on the anticholinergics. All right. So we're talking about the ipratropium. Okay, and another generic name is the tiotropium. So this would be our suffix that you need to keep in mind when we're talking about the inhaled anticholinergics. Okay, so this is an inhaled. This is going to be administered via MDI, or it could be the nebulizer. So if you are going to administer this medication as an inhalation, the onset of the drug can occur within 15 minutes. I wouldn't say it's really not that rapid, but somehow it can help the patient's difficulty of breathing, the wheezing, because it can work within this 15 minutes. And the duration of action will be around 4 to 6 hours. Okay. So it has similarity with the albuterol because of the duration here. 4 to 6 hours, and the drug action, actually it can block the muscarinic receptors of the bronchi, and so this is going to be effective in allowing the bronchodilation. It can relax the smooth muscles of the lungs. Now, since we know that this is an anticholinergic, remember about the side effects of an anticholinergic. Yeah, it can cause dryness, mouth dryness. And this is going to be very uncomfortable when your mouth is really dry. So what are you going to do here as an RN? Well, you're going to have to allow the patient to suck on sugar-free hard candies. Okay? This is a very common intervention that you should know about. This is a must know. They need to suck on sugar-free candies because we really don't want to cause their blood sugar to spike. And so make sure that you are offering them, or at least they have this food item readily available. Now, another thing is you got to be careful with this medication, especially if the patient has narrow angle closure glaucoma. Okay, this is another important check that you should be doing. Make sure that you are asking the patient about their medical history. Do they have any problem with the intraocular pressure, such as this narrow angle glaucoma? Because when they're going to be taking the hypertropium, that intraocular pressure will go up and they're going to have some visual impairment. If the pressure is not going to be relieved inside the eye, yes, it can lead to permanent blindness. So you got to be careful. Now, for the oral or the inhaled anticholinergic, you're going to teach the patient to rinse their mouth after the inhalation. Rinse mouth. This is a must, a very basic nursing care that you should know about when you are dealing with this patient, especially administering the anticholinergic. Now, moving into the next medication, we're going to talk about the corticosteroids, which is very common in the treatment of asthma. So this can come in different forms. It could be inhaled, and one of the popular medication name here is the budesonide. Okay. I hope that you can still recall those medication names. Budesonide. For the systemic IV, we have, or before we go to that, budesonide, there's also that fluticasone, which is going to be the long-acting steroid. Fluticasone. Okay. And moving forward to the systemic corticosteroid, that's the IV. We're talking about the hydrocortisone. This is going to be given as IV. Hydrocortisone or the methylprednisolone. So these are the popular generics. Methylprednisolone. Or we'll simply call them as the Solumedrol, if you still remember that brand name, Solumedrol. And then for the systemic PO, we always have that prednisone. Okay? Prednisone. So this is your clue here for the steroids. The zone, S-O-N-E, methylprednisolone, prednisone, hydrocortisone, fluticasone. The budesonide is one of those medications that doesn't have that zone, so just have to recall that manually. All right, so we know that the corticosteroids does a lot of things. It can really work wonders into the patient. It can prevent the inflammation. It can also suppress the airway mucus. Okay, let me write those down because those are important stuff. Okay, erase. So the corticosteroids will reduce inflammation. And the corticosteroids will also decrease the production of the mucus. M-U-C-U-S. Okay? Decrease the mucus, and also it can also promote responsiveness of the beta 2 receptor. So meaning the patient will be much more respond to the therapeutic effect of the other medications, especially the beta adrenergic agonists. Promote responsiveness. Okay, let me just put here as beta 2 or B2 receptors. So this would really benefit the patient, especially if they're using the beta 2 adrenergic agonists as well. Okay, so recall these drug actions. It can decrease the inflammation, it can decrease the secretions, and also it will allow much more of responsiveness, especially in the beta 2 receptors. Now, guys, we have mentioned probably more than twice regarding the side effects in the past, and I would really keep mentioning it up until you're going to retain this in your subconscious. So what are the side effects? Well, we'll talk first about the common inhaled medication, which is the beclomethasone. Beclomethasone, rather. It's kind of tongue twister here. Beclomethasone. So this is a common corticosteroid that can cause hoarseness in the voice. And guys, this is a steroid, and this is going to be not so helpful if we are not teaching the patient about proper oral hygiene. It can lead to candidiasis, which is basically the presence of yeast infection in the mouth. Have you seen this one in a real patient? That white patches behind the pharynx, or actually in the roof of the mouth, the upper palate, and also to the sides of the mouth and the tonsils. Have you seen those? White patchy, kind of like looking spots. So this is what we call as candidiasis, and this is an opportunistic yeast infection. So we definitely need to keep an eye on this one. Make sure that you notify the medical provider that the patient is now having this kind of infection that needs to be treated with an antifungal agent. So guys, if you are treating the patient with a steroid, these are the common side effects: hoarseness, candidiasis, and on top of that, let me put the list here right on top of the screen. Let me erase this. So what are the other side effects? We really need to know this, guys, because NCLEX can be tricky. It will probably ask that item that you don't know about. Well, if we are treating the patient with, let's say, PO or IV or inhaled steroid, it can suppress the adrenal gland. Oh, let me redo that. It can suppress the adrenal gland. Let me just put an arrow down. The function of the adrenal gland in the body will be somewhat kind of chill. It's going to relax because it's sensing that, hey, I got something else. I have steroid, but it's not coming from me, so I'll just chill. I'm not going to work so hard this time. So the function of the adrenal gland will go down. It will suppress. Let me just put here FXN function. Adrenal function is decreased. And the bone structure will also be affected. There will be bone loss. It can cause resorption, bone resorption, and there is also going to be an elevation of the blood sugar. Let me just write this: BLD sugar. Increase in the blood sugar because it can promote the conversion of other sources into that simple sugar. That's why they're going to end up with hyperglycemia. And this is something that you need to be careful, especially if the patient has a pre-existing diabetes mellitus. they definitely need to have an extra amount of insulin in order to manage their blood sugar. There's also myopathy. There will be some form of muscle wasting. And for those patients that are taking the steroids as well, they're going to end up with a peptic ulcer disease because the medication can cause irritation into the gastric mucosa. So most of the time when we are treating this patient with a steroid medication, they're probably taking antacid or the H2 receptor antagonist. Could be the proton pump inhibitors, the PPI, like pantoprazole, omeprazole, in order to prevent any more insult to the gastric mucosa caused by the steroid. Now, they're also going to be a higher risk to getting infection. It's because the corticosteroid can cause immunosuppression, and there's also going to be fluid and electrolyte imbalance. And guys, do you remember what kind of electrolyte imbalance that can occur in this patient taking the steroid? Do you remember what electrolyte imbalance that is common in a patient taking a steroid? Well, take your guess, and I'll give the answer shortly. Well, this is going to be the hypokalemia, reduced potassium level. Why? The reason for that is because the medication, the steroid, can actually cause the reabsorption of the sodium. Okay, and also because of the function in the aldosterone that will trigger. Also with that function, it will release more of the aldosterone, and also the increased sodium level. And they are not the best of friends. They are the exact opposite. So when the sodium goes up, the potassium goes down. So you got to be careful here, especially if the patient has some pre-existing heart disease, maybe atrial fibrillation. You got to be careful, guys, because hypokalemia can really do a lot of worse things into this patient. So keep an eye on the potassium and also the sodium level. Now, another is the weight gain. It is because of the water and sodium retention, our patient will end up with a weight gain, and then also hypertension, high blood pressure. And that's why our patient taking the corticosteroids need a whole lot of assessment, taking a look into the laboratory data, taking a look into their vital signs, their blood sugar, their lab work, looking into their intake and output. The weight should be done much more, especially. Okay, so these are the things that you need to keep an eye out. And you might encounter this when you're going to be asked in a bow tie type of question. Parameters to monitor. So there you go. There's a lot of things that you can do for this patient just for the corticosteroid treatment. All right. So what are we going to do for this patient, especially if they are doing or taking the oral corticosteroids, or or oral or the inhaled? So what are you going to do? Well, you are going to instruct the patient to cleanse, rinse their mouth, gargle with water, rinse their mouth. Remember about the candidiasis? So make sure that they are maintaining proper oral hygiene because of the candidiasis. They need to rinse their mouth and gargle with water, and also to monitor for any redness, maybe sores or white patches in the mouth. And also with the candidiasis, let me just write it down here so it will not be confusing. Candidiasis. Increase the volume. Okay. Let's see what I can do in my end. Hang on. just a second here. Okay, I have my volume up already, so I'm not quite sure. Let me do some minor adjustments. All right, can you hear me better this time? I want to see your reaction. Can you hear me better? Hello? Can you hear me better this time? I hope you can. All right. So just type in the message or the chat box if you can hear me better. Okay. Now, for the candidiasis, let's go back to that section. Oops. Let me backtrack on that. And candidiasis. Okay, you can hear me better. So, thank you. Now, have you administered that nystatin suspension, that like liquidy kind of medication, that yellowish kind of thick? It comes in one of those small containers that looks like one of those dipping sauces for McDonald's. Have you seen those packages? The nystatin swish and swallow. You're actually gonna instruct the patient to make sure they mix that suspension pretty well, and then they're gonna have to swish it around their mouth, and eventually they're gonna have to swallow the medication in order to allow coating of that medication into the back of their throat. So this is what we call as the nystatin. This is an antifungal medication. Okay. So this is a very nice stat. Okay, I think I spelled it right. Nystatin. All right. So, and let me rethink here. Okay, we talked about the increasing blood sugar, right, because of the steroid. So our patient that has a blood sugar or the diabetes mellitus. So for example, if they have been checking their blood sugar maybe 4 times a day at home, could be before meals and at bedtime, that's basically 4 times a day. So you're going to be doing the same kind of a frequency as ordered by the medical provider. You do that AC and HS frequency, and because of the hyperglycemic effect of the steroid, this is really going to make the blood sugar spike a little bit more. And so the doctor need to increase the insulin dosing for this patient in order to control the blood sugar. So keep in mind about the blood sugar checks and also the insulin dose to be increased. Let me just put insulin arrow up. Okay. All right, let me erase this section because this is getting way too busy here. So, when the patient probably will start getting better, or after the doctor's prescription for the steroid is almost close to the completion, and most often the medication will be tapered. Okay, so make sure that if you are the nurse taking care of this patient and you're actually responsible for doing the discharge teaching when you are sending the patient to their homes, or let's say the nursing home, or the what do you call this, assisted living, you gotta check the dosing of the steroid. Make sure that this is going to be tapered before it's discontinued. Why? Remember about the adrenal insufficiency? It's because the adrenal gland is used to having an external source of the steroid. The adrenal gland will think that, no, I think I'm just gonna sleep. I'm just gonna hibernate because somebody is adding some steroid into the body. So I'll just relax. So if in case there is no tapering of the medication, if there is an immediate stop of that medication, this can lead to the adrenal insufficiency, and this is life-threatening because the patient will end up with hypotension. They're not going to be able to really respond to any kind of stress. Okay, so there are going to be so many problems with this patient. their blood pressure can go down. Oh, let me redo that. Their blood pressure will go down. They're going to be hypotensive. And also their blood sugar can also go down that fast. BS, blood sugar. And again, they're going to end up with the flight response rather than the fight. Okay. So that's pretty much it regarding, oh yeah, before I forget, with the fluid retention and sodium retention, let me add here, erase this section. So what would be your care? Your monitoring for this patient taking the steroid in the hospital setting. Well, what are you going to do? You're going to be checking the patient's blood pressure, right? Because it can cause hypertension. And also, you need to weigh the patient daily. Weigh daily. And also check into the lab results. Check lab results, especially the potassium, because it can lead to hypokalemia. And also look into the sodium level because it can cause hypernatremia. Elevated sodium, decreased potassium. Okay. Again, check the patient's blood pressure. And if you're seeing that the blood pressure is trending up, then definitely that needs to be communicated to the medical provider. Make sure that we are treating that with some antihypertensive medication and also weighing the patient daily. So if there is significant weight gain, maybe around 2.2 pounds weight gain daily, you need to address this. You got to notify the medical provider because this can also lead to some other problems, especially that your patient may end up with some fluid overload. If they have congestive heart failure, that would do a whole lot of things. And also the potassium level, like I have said earlier, if your patient has a history of atrial fibrillation, if your patient is hypokalemic, that's not a good mix either. And Badil, is it how you say your name? Dituson? Yeah, the signs of infection, of course. With a patient taking the corticosteroids, some of them probably would not manifest the fever. So you gotta pay attention to the patient's white blood cell count in the CBC, okay? Because this can also elevate that. And like I said, most of these patients probably will not manifest the fever. So what you're gonna watch for is the fatigability of the patient, EC fatigability. They feel so exhausted. And also look into the IV lines, the central lines, the color of their urine, if it's going to be cloudy, okay? Have they developed some form of urinary tract infection, okay? And also look for any presence of drainage in the IV sites, central lines. Take a look into those areas to see if there's any abnormal drainage, all right? So that's pretty much it. Let's move forward with the next classification. Yeah, that just about the corticosteroids, and my slide here got so busy. Let me erase all those. So let's talk about the leukotriene modifiers. So what is this classification? Well, basically, the leukotriene modifiers can also reduce the inflammation. It has that suppressive effect. So let me just write this first. Suppresses leukotrienes. So what are these leukotrienes? Well, they are part of your chemical mediators, right? That are going to be released in response to a trigger. Could be an allergen. So the leukotrienes will be elevated in asthma. And this medication can help suppress this chemical mediator because what we know of about leukotrienes, it can cause inflammation, and we are talking about the inflammation of the airway. So this is going to be reduced by that. Also, the edema in the airway will also occur when the leukotrienes are released. There's also going to be increase in the mucus. So that's why our leukotriene modifiers can work wonders in our patient with asthma. So this is represented by the Montelukast or the Zafirolukast. Okay, so that is those are the other names of the leukotriene modifiers. So how fast the Montelukast can work? Well, it has an onset of about 3 to 4 hours. It's not that rapid, really. I probably would say like moderate. And the duration, it's going to last for about 24 hours. Okay? So again, let me rewrite that. Erase, erase. So that's 24 hours. For the duration, it has an onset of 3 to 4 hours. Now, the leukotriene modifiers can also lead to some side effects, and this is something that probably gets neglected more often because people would probably think that this is a mild form of the medication, but no. The Montelukast or the leukotriene modifiers can cause depression. And the mechanism about this is quite unknown. It can lead to depression. It can also lead to suicidal ideation, guys. So you gotta screen your patient for any suicidal thoughts before you initiate this medication into their regimen. Okay, so depression, suicidal ideation, and it can also cause liver injury. And so you're going to have to really keep an eye into the LFTs, the liver function test. Look into the enzymes, AST, ALT, before initiating the therapy, and periodic checking, let's say monthly basis, in order to prevent the liver injury. Now, be careful, guys, when you are administering the Montelukast or the leukotriene modifiers, because it can also increase the warfarin levels. You still remember what the warfarin is all about? Yeah, that's the oral anticoagulant that we give to our patients that may have some DVT or may have some issues with other clots, maybe pulmonary embolism. And if the warfarin level increases in the blood, they're going to be prone to developing massive bleeding. And so be careful. Make sure that you are screening your patient. Make sure you ask them, investigate of what other medications that they're taking in order for us to promote safety. Now, moving into another group of medications here, let me erase this. Talking about the immunomodulators. So a little bit more fancy this time. Immunomodulators can do a lot of wonders here. This is represented by the omalizumab, and the onset of the medication is very slow. It can start working within a week's time. Very slow. And the duration, so let me put O here, that's the onset. For the duration, that's the D, it can last for 2 to 4 weeks. Okay. And so how is this immunomodulator taken by the patient, or the omalizumab rather, tongue twister? So this is a medication that is considered as a monoclonal antibody that will target the immunoglobulin E. Okay. The IgE can help our body sometimes, but it can be a menace as well, especially in the case of asthma. So the medication will target the IgE. It will bind to, you'll have one to monitor, well, one, we'll have, please, will one have to monitor, what's the RFT, while administering leukotriene modifiers? What is the RFT? Is that, did you intend to type that as RFT, or did you mean something else? Please, sir, will one have to monitor RFT? Oh, did you mean LFT, liver function test, for the leukotriene modifiers? Is that what you were asking? LFT, or is that the, are you referring to LFT or RFT? I'm not quite sure about the RFT. Okay, I will wait. Oh, the renal function test. Well, with the medication, um, probably at some degree, but it's not really going to be affecting whole lot into the kidney. Okay, but if the patient may have some pre-existing kidney dysfunction, then you might be a little bit more worried around this time. Okay, but for those people that may not have any pre-existing renal function problem, then probably not going to be one of the priority. But it wouldn't hurt if you're going to look into the renal function as well, the creatinine and also the GFR or the EGFR. Okay. Now talking about the immunomodulators, where are we at? Yes, immunomodulators, the omalizumab. So what is this medication all about? Well, again, it is going to target the IgE, the immunoglobulin E, and this is going to be given as a subcutaneous medication. You might see that SQ or SC or subcut as the new abbreviation for the subcutaneous. So yeah, just refer to your notes here. So SQ or subcutaneous, this is going to be given every 2 to 4 weeks. And the medication is going to be, like I've said, the duration of action will be a lot longer. It's slow acting as well. I mean, the onset of action is very slow. Okay. Now, what are we going to do here, especially with this kind of medication? This is something that we need to keep an eye on. Watch your patient for any anaphylactic type of reaction. Okay. Especially for the first few doses, because this is the critical time that the body will try to kind of get a feel of how this medication can do this therapeutic effect inside the body. And so make sure you watch for any signs of anaphylaxis. And of course, you're going to think about the airway, the breathing as well, because it can possibly cause some closure into the airway, which is kind of like paradoxical. Now, when you are the nurse injecting this medication, especially when you are giving this at a clinic or maybe in the doctor's, the clinic, well, you're going to observe the patient for the first 2 hours for any signs of anaphylaxis. And then this is going to occur at least for the first 3 doses. You have to really watch for your patient for this duration. Please 2 hours to watch for the anaphylaxis. Now, talking about the next classification, let me erase that. We have the mast cell stabilizers. And here we have the cromolyn sodium, which is another old medication, but can still do a lot of wonders. So what is the function of the cromolyn sodium? This is going to prevent the release of the histamine, which is another chemical mediator that will be released by the body in the presence of an allergen or any triggering substance. So this will decrease the release of histamine. Okay. Now, this will also work very slow. So the onset of this medication can be within 1 to 2 weeks. And the duration of action is somewhere between 8 to 12 hours. Okay, onset is 1 to 2 weeks, and the duration of action is about 8 to 12 hours. Kind of weird why it has that shortened kind of a duration of action, less than 24 hours, but the onset is kind of slow. Now, we're going to watch for this patient for the side effects. So what are the common side effects in this patient taking the cromolyn sodium? They are going to be taking the drug as an inhalation, and so they're going to experience some throat irritation. They're going to end up coughing. They're going to be wheezing. There's also nausea, headache. So these are the common side effects that you need to watch for in this patient taking the cromolyn sodium. Throat irritation, cough, wheezing, which I forget to write down, headache, and nausea. However, though, in some cases, very rarely, it can lead to bronchospasm. That's why we have the wheezing here. Okay. Now, when you are going to be administering this medication for this patient that probably is just starting this cromolyn sodium in their therapy, then you gotta have to administer that medication at least 15 to 20 minutes before they're going to be exposed to a known allergen. 15 to 20 minutes. So make sure that you're going to instruct the patient that before they're probably going to engage into an activity. Maybe if they're going to be going outside and probably there would be exposure to that known allergen, then they definitely need to get that medication or self-administer the medication at least 15 to 20 minutes before they will expose themselves to that asthma trigger. Okay, kind of sounds stupid, but you know, there are some people that could not really avoid doing it because maybe it's their way of living. Maybe that's their kind of occupation that they just can't avoid. And so they need to be taking this medication in order to decrease their chances of developing the inflammation in their lungs fields. Now, the patient who will be taking the last classification, let me erase this, the beta-2 adrenergic agonist, or the beta-2 adrenergic agonist, and this is represented by the albuterol, which is something that you've known pretty much, maybe much more frequently. Probably who had administered this to your patient as an MDI, or it could be a nebulization. It can be in a form of short-acting, or it could be long-acting. So this is a short-acting, and we also have the long-acting, which is the salmeterol. So you see here, guys, the onset of the albuterol is very rapid. It can work within 2 to 5 minutes after inhalation, and the duration of action is pretty much similar to the ipratropium. It can last for 4 to 6 hours, and probably if you have a prescription to administer the nebulizer to this patient in the hospital setting, let's say every 4 to 6 hours PRN for wheezing, then you can administer safely that medication. Now, for the home setting, they probably would be using the salmeterol, which is the long-acting type. The onset is slow, 30 to 50 minutes, and the duration is 12 hours. Okay? But again, it is more of a preventive medication in order for them to not experience any of that inflammation if in case they get exposed to the triggering substances. Now, that is pretty much it. Now we'll talk about the other treatment, which is basically the IV magnesium. Have you heard about the IV magnesium being used in the treatment of asthma attack in the acute care setting? Have you seen this? All right. Well, this is considered as a third-line treatment for asthma attack, especially for those who are not responding to the beta-2 adrenergic agonist. And it has that effect on the smooth muscle of the lungs. It can cause bronchodilation. So, have you remembered about the therapy, especially in a patient with the pre-eclampsia, that magnesium IV is one of those modalities? You're going to administer this medication as an IV infusion in order to prevent the contraction of the uterus. Yes, it can also work pretty similar, but here we're talking about the lungs. It can promote broncho relaxation, I should say. Relaxation of the airway. And so this is really going to help out the patient. Bronchodilation, I should say. However, though, the patient taking the magnesium might end up with, I should say, some form of tremors. You gotta be careful as well with this drug. It can also cause their blood pressure to go down. So you gotta watch out for these side effects here. Now, for the other medications here, we have, or the other treatments, we have the oxygen supplement, and this is something that you can administer to the patient, starting with the low flow group oxygen. And if the patient doesn't respond to the low flow, then you probably would need to give the oxygen via the mask, or could be the Venturi mask. And if in case they're not going to respond to that, then probably with the use of the BiPAP, or maybe the mechanical ventilation would be the last resort. Now, if in case the patient's asthma is associated with a known infection, then definitely we're going to add the antibiotics in their therapy. And also to fight the infection, like I've said, mechanical ventilation be one of the modalities of the treatment. Now, guys, don't be surprised. In this slide, I've condensed everything that might be present in this patient with acute asthma attack. Sure. Okay. Yes, we'll go back to that before we move to the scenario. So we are talking about the theophylline. Okay, so we have a request from Badil. Is that how you say your name, Badil Tituson? Okay, please correct me if I made a mistake. Okay, so for the theophylline, this is again one of the oldest medications known to treat the asthma. It's a known bronchodilator. So the medication can be given either as IV or oral. Okay. Now take note here for the onset of action for the oral route. It will be 1 to 2 hours. It will take time for the medication to travel, and also with the first pass effect, right? Remember about the first pass effect in the pharmacology. Any of those oral medication, once they get ingested, they have to go through the circulation from the GI tract, let's say the small bowel, and they get absorbed by the circulation, and they will pass through the liver. And remember, the liver will kind of slow down, or it will kind of cut some percentage of that medication. So it's not going to fully receive the entire strength of that medication that the patient has taken. So there is like a cut of the total dosage, okay? And so the onset of action will be affected. It's going to be slowed. And even though with that slow onset of action, the duration of action will be somewhere between 6 to 8 hours, okay? And this is for the immediate release. I don't think I've mentioned this. Okay, for the immediate release oral theophylline, the onset of action is the onset of action is 1 to 2 hours, but the duration is 6 to 8 hours. Now, if the patient is taking the extended release, ER, then we're going to expect that the duration of action will be much more prolonged. It will be 12 to 24 hours. Half a day to at least 24 hours. So that's about the theophylline PO. Now, if we are talking about the IV theophylline, IV, the onset of action is expected to occur within 15 minutes after you have given that medication intravenously, and the duration of action will be 4 to 8 hours. Now, what is the therapeutic effect of the medication? It can cause bronchodilation. It will relax the muscles in the lungs, the airways, the bronchus, bronchioles. And This is a medication that has lost its popularity in the present time. It's because of its adverse effect. And like I have mentioned earlier, that one of those is dysrhythmias. This, let me rewrite that. Dysrhythmias. Of course, nobody wants to experience any of these, right? Especially if this is taken in the home setting. Nobody. So one of the complications or adverse effect is dysrhythmias, and another is the seizures. So these are common adverse effects. Now, I've never seen any more in the recent years about the use of the theophylline for the inpatients that I have dealt with. I've never seen this. However, though, if in case the medical provider still prescribe this medication, you have to be careful. And if in case you will encounter the adverse effect in the acute care setting, you have to prepare yourself to administer the following. If the patient will end up with a seizure episode, the drug of choice here would be the diazepam to control the seizure activity. And to treat the dysrhythmias, then we're gonna expect administering the lidocaine to allow resumption of a normal cardiac activity. Okay. Now, talking about the therapeutic range, like I've said earlier, this medication can do some toxic effects if we are not monitoring the drug level. But to give you an idea, the therapeutic range, this is going to be somewhere between 5 to 15 mcg per ml. That's the therapeutic range, 5 to 15 mcg per ml. That is the normal therapeutic range. So you have to keep an eye on this one all throughout the therapy. Okay. All right, so I hope that helped. Let's move back to the discussion here. Okay, so here in this slide, you will see about the different manifestations that you might encounter in a patient with an acute asthma attack. So you'll see that the patient may have tachycardia, tachypnea, hypoxemia, color changes, cyanosis. That's not good. That is a huge sign that the patient is not getting enough oxygen. Grunting, there's also nose flaring and retractions of the respiratory muscles. Could be the sternal retractions or intercostal retractions. The patient will be diaphoretic this time. Probably they're going to have the inspiratory, expiratory wheezing. You probably would not really have to use the stethoscope around this time because the wheezing is very audible even in the inspiratory phase. And the patient will end up with some crackles, coarse crackles, stridor, and also they're gonna have that rhonchi. It's pretty much that very noisy passing of the airway, of the air in a bigger tubular airway, let's say the trachea. So this is what we call as the rhonchi. Very noisy passing of air in a narrowed airway, like the trachea or the main stem bronchus. The patient will also have that hyperresonance. So when you are percussing the patient's chest, maybe anteriorly, posteriorly, you will hear that resonance as if you are tapping into one of the percussion instruments. And of course, because of the hypoxemia, they will end up so restless, agitated. They will be confused. They will not be able to speak in full sentences. So probably in just few words there, this is the only thing that they can do, okay? Just a few words, not able to speak in long phrases. So this simply means that our patient is not getting enough oxygen. It's not a good thing. Now, also think about the tripod sitting position. This is classic, guys, in a patient with an asthma, or it could be the discoloration of their lips. They're going to have that cyanotic lips, or maybe the cyanosis around their lips, they get confused, they get more disoriented, and they will end up being less responsive. So guys, I have kind of designed the sequence of these manifestations from being less severe to a more severe towards the end. Okay. Now, what are we going to do here? If you're the nurse taking care of this patient, the patient that has an acute asthma attack, what are you going to do? This is a very common NCLEX question, and make sure that you are doing your critical judgment. So what are you going to do here, guys? You really want to reverse the airflow obstruction. This is ominous. Okay, the patient really has hypoxemia. Okay, so what would you do? Our goal for the treatment in this patient is to quickly reverse the airflow obstruction. We need to correct the hypoxemia and also to reduce the likelihood of having this patient recur, having the recurrence, I should say. Now, what are we going to do? Of course, start with the ABCs. Always think about the airway, breathing, and circulation. So here we have our patient. Make sure that you're going to listen to their lung sounds. Is it patent? Do you hear bronchi? Do you hear loud wheezing? If they're wheezing bad, then the airway is compromised here. Next, look into the breathing. You have to really pay attention to the respiratory rate. Maybe the respiratory rate is in the 30s now. Look into the symmetry of their chest. When they're breathing in, you got to pay attention to that one, because if there's asymmetrical movement or paradoxical movement of the chest, then that is something else. That's flailed chest. Now, pay attention into the use of the accessory muscles, especially the intercostal, supraclavicular, sternal muscles. Take a look if the patient is using a whole lot of those extra muscles, because this is a sign that they're really having the air hunger. They're not getting the oxygen that they need. So make sure that you're also listening to the breath sounds on all the lung fields. Because if you're not hearing any air exchange or no passing of the gas in the alveoli, in the terminal bronchioles, not a good sign, guys. This is probably a start of a lung collapse. And if the lung collapse is probably affecting a huge lobe or a huge chunk of the lungs, maybe 2 lobes, that's not going to be any good. Now, the patient's vital signs need to be checked as well. The oxygen saturation, the arterial blood gas, the level of consciousness should be checked every now and then. So if you're a patient that came into the ER, maybe they were like so agitated, and they probably would still know their birthday, the place where they live. But maybe in the next hour or so, the patient probably is getting less responsive, or probably they are unable to recall their birthday, the place. They are disoriented to time events. That's significant, guys. That simply means that their brain is not getting enough oxygen. You got to do something about it. Now, check also in the skin color. This is part of the circulation, guys. The skin color, the cap refill, the responsiveness, the perfusion to the brain, that is part of your circulation check, okay? So I just want to emphasize this. Airway patency, this means maybe the sound of that bronchi, the wheeze, if there is if those are present, then the airway is probably narrowed. We don't want that to close. So maintain patency. For the B, or the breathing, look for the symmetry, look for the respiration, and also listen to the breath sounds if there's any exchange, air exchange there. So that's about the B. For the C, you're going to look for the cap refill, should be less than 2 seconds, normal. Anything above 2 would be very significant. If your patient has cyanosis surrounding their mouth, if they're going to have that blue tinge in their skin, not a good idea, not a good thing to have. All right, So what are we going to do in this stage when the patient has compromised in their ABCs? We're going to position them in an upright position. Have them sit in 90 degrees to allow long expansion, and also make sure that we are continuously checking their vital signs. Make sure that you have connected that pulse oximetry the whole time in order to capture any worsening of their hypoxemia. Now we're going to have to make sure that we're administering the oxygen this time, and make sure that you have the intubation tray equipment close to you, because this patient probably will end up with respiratory arrest. So this is the next step after you assess the ABCs. Now, you're going to have to administer the O2 with humidification via face mask. And most of the time, it will probably be the face mask or the non-rebreather, probably because they're not going to respond to the nasal cannula. We're going to have to check for the labs, and this can happen overlapping with your assessment. So make sure you're checking into the results, the complete blood count, the chest x-ray, and also you're going to have to notify the medical provider in the ED for the abnormal lab results. Also look into the chest x-ray, notify them if they have not seen the results yet, and make sure they also see the complete blood count result. Now, as soon as we get the order from the medical provider, administer the rapid-acting bronchodilators, and I'm talking about the beta-2 adrenergic agonist, the albuterol. That is our rescuer this time. So make sure that you administer that first, followed by the steroid. Okay, guys? You definitely need to do the bronchodilator first before administering the steroid, because if you're administering this as an inhalation, the patient will not get the entire benefit if the airways are not dilated yet. So make sure that you have administered the bronchodilator first to allow the passage of the steroid into the airway. However, if the patient has an order to be given the IV, it should not matter. Okay, so this is the caveat here. If the order is IV steroid, then you can just administer. Well, of course, you're going to start with the bronchodilator anyhow. So let me just write this. Okay. So after that, what are we going to do? Well, we're going to administer short-acting beta-2 agonist, and also administer the ipratropium, which is the anticholinergic. It has the bronchodilatory effect within 5 minutes. And also the methylprednisolone, which is the IV. Remember about the onset of this medication? Yes, it can work as well to decrease the inflammation. And moving forward, let me erase that. We're going to monitor the patient for any more shortness of breath, to see if there is dyspnea or any more audible wheezing. Because if this is going to persist, even though you had administered the bronchodilators, methylprednisolone, ipratropium, then this is now the possibility that the patient will end into respiratory failure, or let's say much worse respiratory distress. Now, around this time, we really need to make sure that we have an IV started for this patient. And also, we are going to have to monitor the patient's subsequent EVGs, because in the critical phase, there should be subsequent checking of the arterial blood gases in order to monitor if the patient is deteriorating, or let's say if they are improving. Okay, so we're going to have to review that, report the values to the medical provider if they are significant, and then if in case the patient is not responding to the treatment, they might end up with a respiratory arrest, then we're going to have to perform the resuscitation, right? So you're going to go through the CPR algorithm if the patient will end up in that direction. So we're going to make sure that we're also checking the patient's vital signs for normalcy as soon as we have provided the resuscitation to this patient. So that's pretty much it about the acute phase, and those are the nursing interventions that we should be providing to the patient. Now we will talk about the normal, or the regular nursing actions that we can do in a non-critical state. Okay, so what we're going to do here is to assess the patient's vital signs, routinely checking the blood pressure, the heart rate, the respirations. We're going to have to check for any presence of cough, chest tightness, maybe wheezing, changes with the activity, or let's say intolerance in doing so many of those activities that they can do in the past. Let's say nighttime asthma awakenings, or let's say if they are using the albuterol more often than the requirement, then that's not a good sign, guys. If they're using the albuterol more frequently, that's not a good sign. And so also ask the patient if they probably have some recent unscheduled ER visits. That simply means that their asthma is not managed well. Remember about that severe persistent? Yeah, that patient needs to be seen by the medical provider more frequently, making sure that they should have that steroid incorporated in their therapy. But if they are non-compliant, then that's the bad thing about it. So part of the care here in the assessment is to make sure we are auscultating for the breath sounds. This is very important to capture those adventitious sounds. Could be crackles, the wheezing, the absence of the breath sounds that may signify lung collapse. Also, you need to assess the patient for any triggers that they know about. So we can reinforce in their teaching to avoid these known triggers, these known allergens. Now, we're also going to make sure that our teaching will be geared towards compliance in their medical or the pharmacological treatment, because if they're not really taking the medications that we're prescribed at home, they're not really going to be able to do a whole lot of stuff at home. Yeah, they will frequently encounter those asthma attacks in maybe daily basis. Now, we're also going to have to teach them about the inhaler technique, and this is very important, guys, especially for those using the meter dose inhaler. It is very important that you're going to teach them about the use of the spacer. Have you encountered this one? Spacer. The spacer is actually an extra gadget that can be connected into the meter dose inhaler. And the purpose for that is to allow much better distribution of the albuterol into the terminal bronchioles. Okay, let me repeat that. The spacer is another gadget that can be connected into the MDI. It's just like a bigger tube that can be connected to the inhaler in order to facilitate delivery of the albuterol or the medication to reach into the terminal bronchioles. So the better, what you're going to expect here is that the patient will have much better results when they take the medication, because they have the medication evenly distributed into the terminal bronchioles. Okay. Now, also, we are going to monitor their vital signs, the skin color, their oxygen saturation, their restlessness, to capture any worsening of their condition. We're going to have to administer the oxygen and also known medications. Could be the bronchodilator, anticholinergics, the immunomodulators, could be the what else? Anticholinergics, the corticosteroids, IV. So those are the things. And we're gonna have to monitor their airway function. And this is the value, or this is the significant pulmonary test that we need to determine, guys. The peak flow meter. So what is this? This is going to assess the patient's airway function as well. Okay, so we will talk a little bit more of that in the next slide. We're also going to encourage the patient to take in more fluids, and this is going to liquefy their secretions to help them expectorate those mucoid secretions. We're going to have to assist them in positioning in order to facilitate breathing and make sure that they are doing their breathing techniques, let's say adaptive breathing techniques like the pursed lip breathing. I don't want you to miss this, guys. Pursed lip breathing. Oops, I lacked the D. Let me erase that. Pursed lip breathing. Have you done this to your patient? Have you instructed your patient to do the first lip breathing in your clinicals? First lip breathing. So the reason that we're going to incorporate this in our teaching is to reduce the work of breathing in our patient. It will allow the exhalation of the air inside their lungs. It will also help them calm down quite a bit. Okay. Now, another interventions that we need to do is to make sure, oh yeah, I said about the spacer. Okay, so I'm not going to repeat that anymore. There's also a need for us to check for the LFTs this time, especially for the Xyloton or the Montelukast. Okay, so these are what? Montelukast classification. So to make sure that you have the baseline information in their liver function in order for us to safeguard the patient for the possible adverse effects that they're going to experience with the drug. We're going to have to teach them how to, or teach them to identify the manifestations so they can report to us those signs that they will experience. Okay. Now, also make sure that you are teaching the patient regarding reporting the abdominal pain, the nausea, the itching, and the jaundice. These are all signs of the liver impairment. Now, we're also going to teach them about the long-acting beta-adrenergic agonist awareness. So make sure that they are not using this medication to treat acute asthma attack, because these are not gonna work. Okay. All right. Okay, we're good. So make sure that you are checking on the patient's awareness in the usage of the LABA or the long-acting beta-adrenergic agonist, because again, they are not going to be effective in treating the acute asthma symptoms. So make sure that they're aware about this, or else they're just going to keep using the long-acting beta-adrenergic agonist. Okay. Another is theophylline monitoring. This is very important, guys, especially that it has that narrow therapeutic effect, or narrow therapeutic range rather. So that is the 5 to 15 micrograms per ml. Okay. So you got to be careful here, especially with these medications. Like I have said, they can experience those dysrhythmias and also the seizures. Now, with the SABA usage, which is the short-acting beta-adrenergic agonist, okay, the SABA, you need to warn the patient that, especially if they're trying to use this more frequently, maybe more than twice a week, or let's say if they are experiencing that they are not really getting the relief in their shortness of breath, that simply means that the medication, or they are not controlling their asthma. So what they should need to have is the anti-inflammatory, okay? And that's, again, the corticosteroid. So what I actually wanted to explain here is that if they are using the short-acting beta agonist, and if they are experiencing more SOB or shortness of breath in a week, or probably increase in the frequency of this medication, if they are using this a whole lot more, then that simply means that they are poorly controlling their manifestations. Again, this will require the medical provider to introduce the anti-inflammatory medication, such as the corticosteroid, okay? Remember about that table that I showed you earlier? Let me go back to that so you will have that visual. Remember the screen right here?
regarding the severe persistent and the moderate persistent. When this patient will have more of the symptoms, exacerbation of the asthma attack, they definitely need to have the corticosteroid implemented into the therapy. Okay, so going back, let's backtrack here. Okay, breathing techniques, we're done with that. What else? Now we're going to talk about the use of the peak, what is this? Peak flow procedure. So this is going to be taught to your patient while they are still in the hospital, especially for those newly diagnosed asthma patients. So make sure that they understand the reason why they have to monitor themselves with this the peak expiratory flow meter. Okay, so what is this device? This is actually this one right here. I don't know if you have seen this device in the clinical setting, but what it does is to actually help determine the severity of their condition, that they're not able to do the proper inhalation once they use this device. So what are we going to do here is to make sure that the patient is aware about the measurement. Okay, make sure that you encourage them to stand up, or let's say sit upright, while they are using the mouthpiece or the device itself. So this device will actually measure, so let me write this down. It measures how fast the air can come out of the lungs. So that is the reason why they need to use this device. It will measure how fast the air, the exhaled air, to come out from their lungs during a forceful exhalation. Okay, so this is the reason why we need to determine this. Okay, now this is something that they need to use at home much more frequently if they have exacerbation of the asthma attack. Okay, now what we're gonna instruct them is to have them take a deep breath, and after that we're gonna have them place the meter mouthpiece in their mouth and making sure that they're sealing their lips around the mouthpiece. And after they have done that, they need to blow out hard and fast in one continuous breath. Again, they need to make sure that they're sitting upright. They know the instructions, that they are quite with it, that they understand the reason. And then you're going to have to instruct them to take a full deep breath. And after that, they're going to have to place their mouth, seal their lips around the mouthpiece, and make sure that they blow out very fast in one continuous breath. Then after that, they need to record their value that they have obtained. Okay, so these are the values now. So let me, before we go into the values, let me show you that. So the peak flow meter is basically like this one. So there's that indicator here, that red zone, the yellow zone, and the green zone. Okay, when the patient is in the red zone, then that's something bad. Okay, that simply means that the patient needs immediate help if they are in the red zone. Okay, if they're in the yellow zone, then they need to follow the action plan. The treatment plan should be followed. Okay, and then for the green zone, that simply means that the patient is actually achieving good asthma control. Okay, so think about the green, yellow, red. So the greener it is, the better they are managing their manifestation. So let's go back here. So the values again, green, it's about 80 to 100%. That means they have good asthma control. For the yellow zone, it means that their performance is about 50 to 80%, and they need to adhere to the treatment plan, make sure that they are compliant with the medication regimen, and also notifying the medical provider regarding the manifestations that are probably signs of worsening. And also the red zone is basically their performance is less than 50%. Again, they need immediate medical attention, okay? So they need to go into the ED right away to relieve the bronchospasm. Now, we're also going to educate them regarding the cleaning of this device and also the MDI, and make sure that they achieve some adequate rest, sleep, and diet. Remember about the insomnia that I mentioned earlier regarding the moderate and the severe form of the asthma? Yeah, they're going to end up being insomniac because they're going to be awakened in the middle of the night, being so short of breath. They're going to be wheezing as well. They need to participate in some form of exercise program in order to maintain bodily function, and make sure that they're up to date with their flu shot as well yearly, in order to prevent any worsening of their condition, especially in the winter season. Also, we need to make sure that they're able to manage their self-care activities as well. And that's pretty much it. So I hope that you're able to capture many things from this lecture. It seems kind of too much, right? It's kind of overwhelming, but you need to know these interventions because these are priority nursing actions that you need to know about, especially in dealing with a patient with asthma in the acute phase. So I hope that you were able to gain some more insights today. And I really would encourage you to review this content and also review in your notes and test yourself. So go ahead and go back into your textbooks. If you have any sets of questions, NCLEX questions that you can use, test yourself again and to see if you're retaining any valuable information, if you're able to synthesize those important nursing interventions. Now, I will see you again tomorrow for the discussion of the next topic, which is on the cystic fibrosis. Okay. Again, I'll see you tomorrow at the same time, 9 p.m. Eastern Standard Time, and we will talk about the cystic fibrosis. So thank you so much for your attendance today, and please make sure you share this video and hit the like and subscribe button, and please share so your friends can also benefit from this free lecture series. Thank you so much and have a great day. Bye-bye. Thank you.